Question 1. A 65-year-old male patient arrives in the emergency department with a chief complaint of chest pain, shortness of breath, and diaphoresis. His medical history includes hypertension, diabetes, and smoking. His vital signs are blood pressure 160/100 mmHg, heart rate 95 bpm, respiratory rate 22 breaths per minute, and oxygen saturation 94%. An egg is performed, showing sense segment elevation in the anterior leads. What is the most appropriate immediate intervention for this patient? A. Administer a thrombolytic agent. B. Administer aspirin and nitroglycerin. C. Prepare for percutaneous coronary intervention ECI. D. Start intravenous morphine and observe for 30 minutes. Answer. C. Prepare for percutaneous coronary intervention ECI. Explanation. The patient presents with signs and symptoms consistent with an acute STEMI segment elevation myocardial infarction. The most critical aspect of care for STEMI is timely reperfusion, either through thrombolytics ECI, the preferred treatment if it can be performed within 90 minutes of first medical contact, administering aspirin and nitroglycerin. Option B is part of the initial management, but reperfusion therapy is essential. Thrombolytics option A are indicated at ECI is not available but should be used cautiously in specific cases. Morphine option D is not appropriate as the first line in STEMI, especially without addressing reperfusion. Question 2. Mr. Johnson, a 47-year-old male, presents to the emergency department with confusion and slurred speech after a sudden headache. He has a history of hypertension, which is poorly controlled. His blood pressure is 210/100 mmHg, and Aiken reveals a right parietal intracerebral hemorrhage. What should be the next step in management? A. Immediate surgical evacuation of the hemorrhage. B. Administer intravenous libitalol to control blood pressure. C. Observation and repeat CT scan in 24 hours. D. Administer recombinant fructoramin or hemostasis. Answer. B. Administer intravenous libitalol to control blood pressure. Explanation. This patient is presenting with an acute intracerebral hemorrhage, which is often associated with severely elevated blood pressure. The first step in management is to control blood pressure to prevent further hemorrhage and reduce the risk of neurological deterioration. Intravenous labetalol is commonly used to lower blood pressure in this setting. Immediate surgical evacuation, option A, is reserved for large progressive hemorrhages or patients with neurological deterioration. Observation alone, option C, is inappropriate in a patient with acute hypertension and recombinant fructoramin, option D, is not indicated unless the patient has a bleeding disorder or is on anticoagulation. Question 3 scenario question. Mrs. Allen, a 72-year-old female, presents to the emergency department with severe shortness of breath, a productive cough, and pleuritic chest pain. She has a history of chronic obstructive pulmonary disease, COPD, and is currently using her albuterol inhaler without relief. Upon examination, she is febrile but has a respiratory rate of 28, heart rate of 102 bpm, oxygen saturation of 88% on room air. A chest X-ray reveals a right lower lobe consolidation. What is the most appropriate next step in management? A. Administer oral antibiotics and send the patient home. B. Administer oxygen, initiate a broad-spectrum antibiotic regimen and consider corticosteroids. C. Perform a ECANTOR rule out a pulmonary embolism. D. Administer diuretics for suspected heart failure. Answer. B. Administer oxygen, initiate a broad-spectrum antibiotic regimen and consider corticosteroids. Explanation. Mrs. Allen's presentation, including the cough, pleuritic chest pain, and consolidation on chest X-ray, is consistent with a bacterial pneumonia. In patients with COPD, pneumonia is a common and serious complication. The most appropriate management includes oxygen therapy, broad-spectrum antibiotics to cover pathogens, and corticosteroids to reduce inflammation and improve respiratory function. Administering oral antibiotics alone, option A, is inadequate in this setting as the patient requires intravenous antibiotics and close monitoring. Aiken option C is unnecessary unless there are concerns for pulmonary embolism, which is less likely in this case due to the lack of risk factors. Diuretics option D would not address the underlying pneumonia and are inappropriate in the absence of clear heart failure signs. Question 4. A 28-year-old male presents to the emergency department with abdominal pain, nausea, and vomiting after eating a large meal at a family gathering. He is experiencing severe epigastric pain radiating to his back. His vital signs are Blood pressure 130/85 mmHg, heart rate 100 bpm, temperature 101 dec, 38.3 dec, and oxygen saturation 97%. Laboratory results reveal an elevated amylase and lipase. Abdominal ultrasound shows swollen, tender pancreas. What is the most likely diagnosis? A. Acute cholecystitis. B. Acute pancreatitis. C. Peptic ulcer disease. D. Gastroesophageal reflux disease. GERD. Answer: B. Acute pancreatitis. Explanation: the patient's clinical presentation, including epigastric pain radiating to the back, nausea, vomiting, elevated amylase and lipase, and swollen, tender pancreas on ultrasound, strongly suggests acute pancreatitis. The most common causes of acute pancreatitis include gallstones, alcohol consumption, and hyperlipidemia, but in this case it may be linked to the large meal. Cholecystitis option A typically presents with right upper quadrant pain, fever, and positive Murphy sign. Peptic ulcer disease option C can present with similar symptoms but would not show elevated amylase or lipase. GERD option D presents with heartburn and regurgitation but would not cause elevated pancreatic enzymes. Question 5. A 45-year-old female with a history of hypertension presents with sudden onset severe headache, nausea, vomiting, and blurred vision. Her blood pressure is 200/128 G and she has a positive fundoscopic exam for papilledema. She is confused and lethargic. A shows no evidence of bleeding, and a lumbar puncture is performed, showing an elevated opening pressure and normal cerebrospinal fluid composition. What is the most likely diagnosis? A. Subarachnoid hemorrhage. B. Hypertensive encephalopathy. C. Meningitis. D. Brain tumor. Answer: B. Hypertensive encephalopathy. Explanation: this patient's symptoms, including severe headache, nausea, vomiting, blurred vision, confusion, and papilledema, are consistent with hypertensive encephalopathy. This condition occurs due to rapid and severe elevation in blood pressure leading to cerebral edema, increased intracranial pressure, and altered mental status. Normal CT scan and cerebrospinal fluid analysis option C help rule out causes like subarachnoid hemorrhage or meningitis. Subarachnoid hemorrhage option A would show evidence of blood on CT or lumbar puncture. Brain tumor option D may cause similar neurological symptoms but would likely present with focal findings on imaging and not the elevated blood pressure and papilledema seen here. Question 6, scenario question. Mr. Miller, a 56-year-old male with a history of alcohol abuse, presents to the emergency department with confusion, tremors, and agitation. He is sweating profusely and has a blood pressure of 145/95 mmHg, heart rate of 110 bpm, and temperature of 100.5 dec, 38 dec. His history reveals that he has not had alcohol for the 48 hours. What is the most likely diagnosis and what should be the next step in management? A. Acute alcohol intoxication. Administer activated charcoal. B. Alcohol withdrawal. Administer benzodiazepines. C. Delirium tremens. Administer thiamine and romanumins. D. Acute pancreatitis. Initiate supportive care. Answer: B. Alcohol withdrawal. Administer benzodiazepines. Explanation: Mr. Miller's symptoms, including confusion, tremors, agitation, sweating, and history of alcohol abuse with cessation for 48 hours, are consistent with alcohol withdrawal syndrome, or benzodiazepines are the treatment of choice to manage withdrawal symptoms and prevent progression to more severe manifestations such as delirium tremens DT. Option: acute alcohol intoxication is not appropriate as his symptoms appear more consistent with withdrawal. Delirium tremens option C can occur 48 to 72 hours after alcohol cessation, but this patient's symptoms are not severe enough to require aggressive intervention like thiamine and romanhuids alone. Acute pancreatitis option D is unlikely as it typically presents with severe abdominal pain, nausea, and vom, not confusion and tremors. Question 7. A 72-year-old female with a history of COPD and heart failure presents with increasing shortness of breath, orthopnea, and bilateral lower extremity edema. On examination, she is tachypneic with a respiratory rate of 24 and an oxygen saturation of 89% on room air. A chest X-ray reveals pulmonary edema. What is the most likely diagnosis and what should be the immediate treatment? A. Exacerbation of COPD. Administer nebulized albuterol. B. Acute congestive heart failure. Administer diuretics and oxygen. C. Pneumonia. Administer broad-spectrum antibiotics. D. Pulmonary embolism. Administer heparin. Answer: B. Acute congestive heart failure. Administer diuretics and oxygen. Explanation: this patient's symptoms, including shortness of breath, orthopnea, bilateral edema, and pulmonary edema on chest X-ray, are consistent with acute congestive heart failure (CHF). The immediate treatment should focus on improving respiratory status with oxygen and decreasing fluid overload with diuretics. Option: COPD exacerbation is less likely because the patient has clear signs of heart failure rather than isolated pulmonary symptoms. Pneumonia, option C, would typically present with fever and purulent sputum, not pulmonary edema. Pulmonary embolism, option D, could present with shortness of breath, but this patient's presentation is more consistent with heart failure and the chest X-ray findings rule out P. Question 8. A 34-year-old male presents with severe right-sided flank pain, hematuria, and nausea after lifting heavy boxes at work. His vital signs are stable, but he is in significant pain. A non-contrast CT scan shows a 4 mm stone in the right renal pelvis. What is the most appropriate initial management for this patient? A. Immediate surgical removal of the stone. B. Intravenous fluids and opioid pain management. C. Oral antibiotics and hydration. D. Admission for observation and repeat imaging in 24 hours. Answer: B. Intravenous fluids and opioid pain management. Explanation: this patient's presentation is consistent with renal colic due to renal stone. The initial management includes providing adequate pain relief, often with opioid analgesics, and ensuring proper hydration with intravenous fluids. Stones less than 5 mm often pass spontaneously, and invasive interventions are not typically required unless the stone is larger or complications. Option: immediate surgical removal is not necessary for small stone without complications. Oral antibiotics, option C, are not indicated unless there is evidence of infection such as fever or leukocytosis. Admission for observation, option D, is unnecessary in the absence of complications or progressive symptoms. Question 9. A 60-year-old male with a history of diabetes presents with severe shortness of breath, fatigue, and dry cough for the past 2 weeks. His vital signs show a respiratory rate of 22, heart rate of 9 EPM, blood pressure 130/85 mmHg, and oxygen saturation 94%. A chest X-ray shows bilateral pulmonary infiltrates. His blood sugar is 200 mg/dL. What is the likely diagnosis? A. Community-acquired pneumonia. B. Acute exacerbation of COPD. C. Pulmonary edema from heart failure. D. COVID-19 pneumonia. Answer: D. COVID-19 pneumonia. Explanation: given the current pandemic and the patient's symptoms including shortness of breath, fatigue, dry cough, and bilateral infiltrates on chest X-ray, COVID-19 pneumonia is the most likely diagnosis. Diabetes is a known risk factor for severe disease. Community-acquired pneumonia, option A, would be considered, but COVID-19 remains a top differential given the clinical picture. An exacerbation of COPD, option B, is unlikely without a history of increased sputum production or a trigger like an infection. Pulmonary edema from heart failure, option C, is not supported by the X-ray findings, which show bilateral infiltrates rather than fluid accumulation in the lungs. Question 10. A 45-year-old female presents with sudden onset dizziness, palpitations, and chest discomfort. Her vital signs are heart rate 140 bpm, blood pressure 130/85 mmHg, respiratory rate 18 EPM, and oxygen saturation 98%. An ECG reveals a regular narrow complex tachycardia with a rate of 140 bpm. What is the most appropriate treatment for this patient? A. Administer intravenous adenosine. B. Administer oral beta blockers. C. Perform immediate synchronized cardioversion. D. Start intravenous fluids and monitor. Answer A. Administer intravenous adenosine. Explanation: this patient's presentation is consistent with paroxysmal supraventricular tachycardia (PAT). The treatment of choice for PAT is intravenous adenosine, which can terminate the arrhythmia by blocking AV node conduction. Beta blockers, option B, are not first-line treatments for a PAT. Synchronized cardioversion, option C, is only indicated if the patient is hemodynamically unstable or if pharmacological treatments fail. Intravenous fluids, option D, are not indicated unless the patient is hypotensive or showing signs of dehydration. Question 11. A 25-year-old male presents with a sore throat, fever, and difficulty swallowing. On examination, he has erythema and swelling of the tonsils with exudates. His temperature is 102 38.9 ic and his heart rate is 110 bpm. Rapid antigen test for group Streptococcus is positive. What is the most appropriate treatment for this patient? A. Intravenous antibiotics. B. Oral penicillin. C. Over-the-counter ibuprofen. D. No treatment needed. Answer: B. Oral penicillin. Explanation: This patient has symptoms consistent with acute pharyngitis caused by group a Streptococcus strep throat. The first-line treatment is oral penicillin or amoxicillin. Intravenous antibiotics, option A, are not typically required unless the patient is severely ill or unable to take oral medications. Over-the-counter ibuprofen, option C, can help with symptom relief, but antibiotics are necessary to treat the underlying bacterial infection and prevent complications such as rheumatic fever. No treatment, option D, is incorrect because untreated strep throat can lead to serious complications. Question 12. A 65-year-old male with a history of smoking presents with a persistent cough, weight loss, and hemoptysis. His chest X-ray shows a spiculated mass in the upper lobe of the right lung. The patient is referred for a biopsy which confirms non-small cell lung cancer (SLC). What is the most appropriate next step in management? A. Immediate chemotherapy. B. Surgical resection if the tumor is operable. C. Palliative radiation therapy. D. Observation with regular imaging. Answer: B. Surgical resection if the tumor is operable. Explanation: The most appropriate next step for a patient with non-small cell lung cancer (SLC), depending on the tumor's operability, is surgical resection. If the tumor is localized and resectable, surgery provides the best chance for long-term survival. Chemotherapy, option A, may be considered after surgery or for patients with advanced disease but is not the first step for tumors. Palliative radiation, option C, is reserved for patients with advanced or inoperable cancer. Observation, option D, is not appropriate in the setting of confirmed cancer. Question 13. A 45-year-old female presents with a history of chronic abdominal pain, bloating and alternating diarrhea, and constipation. These symptoms have been occurring intermittently for the past year. She denies any weight loss, fever, or rectal bleeding. On physical exam, she has mild lower abdominal tenderness, but no signs of an acute abdomen. What is the most likely diagnosis? A. Irritable bowel syndrome (IBS). B. Celiac disease. C. Inflammatory bowel disease. D. Colon cancer. Answer: A. Irritable bowel syndrome (IBS). Explanation: The patient's symptoms of chronic abdominal pain, bloating, and alternating diarrhea and constipation are characteristic of irritable bowel syndrome (IBS), a functional gastrointestinal disorder. IBS typically presents without weight loss, fever, or rectal bleeding, which helps differentiate it from other conditions such as inflammatory bowel disease or colon cancer. Celiac disease, option B, may present with gastrointestinal symptoms, but usually includes malabsorption or nutrient deficiencies. IBD, option C, often presents with bloody diarrhea and weight loss, which this patient does not have. Colon cancer, option D, is less likely in the absence of rectal bleeding, weight loss, or other red flag symptoms. Question 14. A 28-year-old female presents with a history of fatigue joint pain and a butterfly-shaped rash across her cheeks and nose. She also reports photosensitivity and mouth ulcers. Laboratory results show a positive anti-nuclear antibody on a test and elevated DNA antibodies. What is the most likely diagnosis? A. Rheumatoid arthritis. B. Systemic lupus erythematosus. C. Sjogren's syndrome. D. Dermatomyositis. Answer: B. Systemic lupus erythematosus. Explanation: The patient's symptoms, including fatigue joint pain, a butterfly-shaped rash, photosensitivity, mouth ulcers, and the presence of positive on and DNA antibodies, are consistent with systemic lupus erythematosus. SLE is an autoimmune disorder that can affect multiple organ systems. Rheumatoid arthritis, option A, typically causes joint pain and deformities, does not present with a characteristic butterfly-shaped rash or positive anti-DNA antibodies. Sjogren's syndrome, option C, often involves dry eyes and dry mouth, but does not cause the characteristic skin rash seen in SLE. Dermatomyositis, option D, presents with muscle weakness and heliotrope rash, but does not have the same autoimmune profile as SLE. Question 15. A 70-year-old male with a history of hypertension and hyperlipidemia presents with sudden onset left-sided weakness, difficulty speaking, and facial droop. His blood pressure is 109 to 100 Hg, heart rate 85 bpm, and oxygen saturation 98%. A non-contrast CT scan of the brain is performed and shows no acute hemorrhage. What is the most likely diagnosis and should be the next step in management? A. Acute ischemic stroke. Initiate thrombolysis if within the therapeutic window. B. Transient ischemic attack. TIA. Start aspirin and statin therapy. C. Acute hemorrhagic stroke. Start antihypertensives. D. Bell's palsy. Initiate corticosteroid therapy. Answer A. Acute ischemic stroke. Initiate thrombolysis if within the therapeutic window. Explanation. The patient's sudden onset neurological deficits, including weakness, speech difficulty, and facial droop, along with non-contrast CT scan showing no hemorrhage, are indicative of an acute ischemic stroke. The next step in management is to evaluate if the patient is within the therapeutic window, typically 3 to 4.5 hours. Thrombolysis with tissue plasminogen activator (EPA). Transient ischemic attack (TIA) option B would cause temporary symptoms without lasting deficits, and this patient's presentation suggests more severe event. Acute hemorrhagic stroke option C is unlikely due to the negative CT scan for hemorrhage. Bell's palsy option D affects facial nerve function and would not explain the other neurological findings. Question 16. A 50-year-old male presents with a history of intermittent chest pain, shortness of breath, and palpitations. He has a 20-year history of smoking and is diagnosed with chronic obstructive pulmonary disease (COPD). An electrocardiogram shows sinus tachycardia with occasional premature ventricular contractions (PVCS). What is the most likely cause of his symptoms? A. Acute myocardial infarction. B. Heart failure. C. COPD exacerbation. D. Pulmonary embolism. Answer B. Heart failure. Explanation. Is patient with a history of smoking and COPD presents with symptoms of chest pain, shortness of breath, and palpitations, along with an X showing sinus tachycardia and PVCS. These findings are more consistent with heart failure, which can present with these symptoms due to poor cardiac output and arrhythmias. Acute myocardial infarction option A is unlikely in this patient, as there are no acute ischemia or elevated cardiac biomarkers. A COPD exacerbation option C could cause shortness of breath, but typically does not present with chest pain or palpitations. Pulmonary embolism option D could also cause shortness of breath, but would usually present with sudden onset pleuritic chest pain and hypoxia. Question 17. A 22-year-old woman presents with a 2-week history of fever, sore throat, and painful swallowing. On examination, her tonsils are enlarged and erythematous with white exudates. Her lymph nodes are swollen and tender. A rapid antigen test for streptococcus is negative. The most likely diagnosis is A. Infectious mononucleosis, B. Streptococcal pharyngitis, C. Diphtheria, D. Tonsillitis. Answer A. Infectious mononucleosis. Explanation. The patient's symptoms of fever, sore throat, painful swallowing, and swollen lymph nodes, along with tonsillar enlargement and exudates, are suggestive of infectious mononucleosis caused by Epstein-Barr virus. A negative rapid antigen test for group A Streptococcus makes strep throat. Option B, less likely. Diphtheria. Option C, presents with a grayish pseudomembrane and is developed countries, particularly in vaccinated individuals. Tonsillitis. Option D is a general term for inflammation of the tonsils, but doesn't specify the underlying etiology. An infectious mononucleosis is more likely given the patient's age and symptoms. Question 18. A 58-year-old man with a history of obesity and type 2 diabetes presents with severe, sharp abdominal pain that began suddenly 6 hours ago. He has nausea, vomiting, and a rigid abdomen. On physical exam, his vital signs show tachycardia, hypotension, and a temperature of 101 dec, 38.3 dec. What is the most likely diagnosis? A. Acute pancreatitis. B. Acute appendicitis. C. Small bowel obstruction. D. Perforated peptic ulcer. Answer D. Perforated peptic ulcer. Explanation. Is patient's acute onset of severe sharp abdominal pain with a rigid abdomen, tachycardia, hypotension, and fever is highly suggestive of a perforated peptic ulcer. This is a surgical emergency that occurs when an ulcer erodes through the stomach or duodenal wall, causing peritonitis. Acute pancreatitis, option A, would present with epigastric pain that radiates to the back and is associated with elevated pancreatic enzymes. Acute appendicitis, option B, typically starts with periumbilical pain that later localizes to the right lower quadrant and is not associated with a rigid abdomen or hypotension. Small bowel obstruction, option C, would present with abdominal distension, high-pitched bowel sounds, and vomiting, but it would not typically cause peritonitis or a rigid abdomen in the same way. Question 19. A 45-year-old female with a history of diabetes mellitus presents with sudden onset right lower quadrant pain, fever, and nausea. On physical examination, she has tenderness in the right lower quadrant with guarding and rebound tenderness. Laboratory results show an elevated white blood cell count. What is the most likely diagnosis? A. Ectopic pregnancy. B. Ovarian cyst rupture. C. Acute appendicitis. D. Urinary tract infection. Answer: C. Acute appendicitis. Explanation: this patient presents with typical signs of acute appendicitis, including right lower quadrant pain, fever, nausea, and physical exam findings such as tenderness, guarding, and rebound tenderness. The elevated white blood cell count further supports this diagnosis. Ectopic pregnancy, option A, it could cause lower abdominal pain, but would typically be associated with a missed period or positive pregnancy test. Ovarian cyst rupture, option B, can cause sudden onset pelvic pain, but is not typically associated with fever or rebound tenderness. A urinary tract infection, option D, would present with dysuria, frequency, and lower abdominal pain, but it would not cause localized tenderness in the right lower quadrant. Question 20. A 30-year-old male with no significant medical history presents with a 3-day history of fever, headache, and a rash that started on his wrists and ankles and has spread centrally. The rash is blanching and maculopapular. The patient mentions he recently returned from a camping trip in a wooded area. What is the most likely diagnosis? A. Rocky Mountain spotted fever. B. Measles. C. Chickenpox. D. Meningococcemia. Answer: A. Rocky Mountain spotted fever. Explanation: this patient's presentation with fever, headache, and a rash that starts on the wrists and ankles and spreads centrally is classic for Rocky Mountain spotted fever, a rare tick-borne illness caused by Rickettsia rickettsii. The rash often begins as maculopapular and becomes petechial. The patient's recent camping trip in a wooded area further supports this diagnosis. Measles, option B, would present with coryza conjunctivitis and a characteristic rash that begins on the face and spreads downward. Chickenpox, option C, would present with a vesicular rash in different stages of development. Meningococcemia, option D, typically presents with fever, rash, and signs of sepsis, but the rash often appears as petechial or purpuric and does not have the typical distribution seen on RA. Question 21. A 65-year-old woman with a history of hypertension and hyperlipidemia presents with sudden onset severe headache, nausea, and vomiting. On physical examination, she has a stiff neck, photophobia, and altered mental status. EK of the head is negative for hemorrhage. What is the most likely diagnosis? A. Subarachnoid hemorrhage. B. Meningitis. C. Cluster headache. D. Temporal arteritis. Answer: B. Meningitis. Explanation: this patient with sudden onset severe headache, nausea, vomiting, a stiff neck, photophobia, and altered mental status is most likely suffering from meningitis and inflammation of the meninges that surround the brain and spinal cord. The negative CT scan makes a subarachnoid hemorrhage, option A, less likely. Meningitis is often caused by infections such as bacterial, viral, or fungal. Cluster headaches, C, typically cause severe unilateral pain, but are not associated with nausea, vomiting, or altered mental status. Temporal arteritis, option D, is a condition that affects older adults and presents with headache, geocortication, and vision changes, but it does not typically cause neck stiffness or photophobia. Question 22. A 40-year-old man presents with a 2-day history of fever, chills, and painful swelling in his right knee. He has a history of intravenous drug use. On examination, the knee is red, warm, and swollen with limited range of motion. Aspiration of the joint fluid reveals purulent material. What is the most likely causative organism? A. Streptococcus pneumoniae. B. Staphylococcus aureus. C. Neisseria gonorrhoeae. D. Escherichia coli. Answer: B. Staphylococcus aureus. Explanation: this patient presents with acute septic arthritis, which is commonly caused by Staphylococcus aureus, option B, particularly in individuals with a history of intravenous drug use. The purulent joint fluid is typical of a bacterial infection. Streptococcus pneumoniae, option A, is a common cause of bacterial infections, but it is less likely to cause septic arthritis in adults. Gonorrhea, option C, is more likely to cause septic arthritis in sexually active young adults, particularly in those with multiple sexual partners. Escherichia coli, option D, is a common cause of urinary tract infections, but is less commonly associated with septic arthritis in healthy adults. Question 23. A 28-year-old woman presents with a 2-week history of fatigue, muscle weakness, and difficulty swallowing. On examination, she has ptosis and generalized muscle weakness. A reflex is a normal. What is the most likely diagnosis? A. Amyotrophic lateral sclerosis. B. Myasthenia gravis. C. Guillain-Barré syndrome. D. Multiple sclerosis. Answer: B. Myasthenia gravis. Explanation: this patient's symptoms of fatigue, muscle weakness, ptosis, and difficulty swallowing are characteristic of myasthenia gravis, an autoimmune disorder that affects the neuromuscular junction. The weakness in myasthenia gravis typically worsens with activity and improves with rest. Amyotrophic lateral sclerosis (ALS) option A would present with progressive muscle weakness and atrophy, but it also causes upper motor neuron signs such as hyperreflexia, which this patient does not have. Guillain-Barré syndrome option C typically presents with ascending paralysis and is associated with history of infection or vaccination. Multiple sclerosis option D is demyelinating disorder that causes neurological deficits but involves sensory symptoms and variable motor weakness. Question 24. A 40-year-old man presents with a history of severe epigastric pain that is relieved by eating, along with weight loss and early satiety. He also has black tarry stools. What is the most likely diagnosis? A. Acute pancreatitis. B. Peptic ulcer disease. C. Gastroesophageal reflux disease (GERD). D. Gastric cancer. Answer: B. Peptic ulcer disease. Explanation: is patient's presentation of severe epigastric pain relieved by eating, weight loss, and black tarry stools, indicating melena, which suggests gastrointestinal bleeding, is most likely due to peptic ulcer disease. Peptic ulcers are common in the duodenum or stomach and may be caused by Helicobacter pylori infection or non-steroidal anti-inflammatory drug NSAID use. Acute pancreatitis or A typically presents with upper abdominal pain radiating to the back and elevated pancreatic enzymes. Gastroesophageal reflux disease (GERD) option C typically causes heartburn and regurgitation, not significant epigastric pain or bleeding. Gastric cancer option D could cause weight loss and epigastric pain, but is less likely to be relieved by eating and typically presents with more systemic symptoms. Question 25. A 70-year-old man presents with a history of progressive memory loss, difficulty finding words, and poor judgment over the last year. His family reports that he often repeats questions and gets lost in familiar places. What is the most likely diagnosis? A. Alzheimer's disease. B. Parkinson's disease. C. Vascular dementia. D. Lewy body dementia. Answer A. Alzheimer's disease. Explanation: this patient's progressive memory loss, difficulty finding words, poor judgment, and repetitive questioning are classic signs of Alzheimer's disease, the most common form of dementia. Alzheimer's disease primarily affects short-term memory, and patients often get lost in familiar places due to cognitive decline. Parkinson's disease option B can cause cognitive impairment, but it is usually associated with motor symptoms such as tremors, rigidity, and bradykinesia. Vascular dementia option C is associated with history of strokes or vascular risk factors and presents with stepwise cognitive decline. Lewy body option D presents with visual hallucinations and Parkinsonism early in the disease. Question 26. A 50-year-old woman presents with fatigue, weight gain, constipation, and cold intolerance. On examination, she has dry skin, bradycardia, and delayed relaxation of deep tendon reflexes. Laboratory studies reveal an elevated TSH level and low free. What is the most likely diagnosis? A. Hypothyroidism. B. Hypothyroidism. C. Hashimoto's thyroiditis. D. Graves' disease. Answer: B. Hypothyroidism. Explanation: this patient's symptoms of fatigue, weight gain, constipation, cold intolerance, dry skin, bradycardia, and delayed relaxation of deep tendon reflexes are consistent with hypothyroidism. Elevated TH and low free T levels confirm this diagnosis. Hashimoto's thyroiditis option C is the most common cause of hypothyroidism and is an autoimmune condition that leads to thyroid destruction, but the clinical features are the same as for hypothyroidism. Hypothyroidism option A typically presents with symptoms such as weight loss, heat intolerance, tachycardia, and tremors. Graves' disease option D is called hypothyroidism, often presenting with exophthalmos and goiter. Question 27. A 25-year-old woman presents with a sudden onset of severe unilateral headache associated with nausea, vomiting, and sensitivity to light. She has a family history of migraines. What is the most likely diagnosis? A. Cluster headache. B. Tension headache. C. Migraine headache. D. Sinus headache. Answer: C. Migraine headache. Explanation: this patient's sudden onset severe unilateral headache with nausea, vomiting, and photophobia is most consistent with migraine headache. Migraines are commonly associated with family history and can be triggered by various factors such as stress, certain foods, or hormonal changes. Cluster headaches, option A, tend to be excruciating and unilateral, but are typically associated with autonomic symptoms such as lacrimation or nasal congestion and occur in cyclical patterns. Tension headaches, option B, are typically bilateral and associated with dull, non-throbbing pain. Sinus headaches, option D, are usually associated with sinus congestion and tenderness, which this patient does not have. Question 28. A 32-year-old man presents with fever, a non-productive cough, and difficulty breathing for the past 3 days. He has a history of asthma, and his vital signs show a respiratory rate of 24 breaths per minute and an oxygen saturation of 92%. What is the most likely diagnosis? A. Acute bronchitis. B. Pneumonia. C. Asthma exacerbation. D. Chronic obstructive pulmonary disease, COPD exacerbation. Answer: B. Pneumonia. Explanation: this patient with fever, non-productive cough, difficulty breathing, and hypoxia, oxygen saturation of 92%, is most likely experiencing pneumonia. Pneumonia often presents with symptoms such as fever, cough, and difficulty breathing. In this case, the respiratory rate and hypoxia suggest more significant respiratory distress, typical of pneumonia. Acute bronchitis, option A, typically presents with a cough lasting for more than 5 days, but it does not cause hypoxia or fever to the same extent as pneumonia. Asthma exacerbations, option C, can cause difficulty breathing, but they are usually not associated with fever or productive cough. COPD exacerbations, option D, are more common in older smokers and present with increased sputum production and wheezing. Question 29. A 60-year-old man with a history of chronic alcohol use presents with confusion, ataxia, and ophthalmoplegia. He is unable to walk without assistance and exhibits nystagmus. What is the most likely diagnosis? A. Wernicke's encephalopathy. B. Acute alcohol intoxication. C. Stroke. D. Alzheimer's disease. Answer: A. Wernicke's encephalopathy. Explanation: this patient's confusion, ataxia, ophthalmoplegia, and nystagmus are classic signs of Wernicke's encephalopathy, condition caused by thiamine deficiency, often due to chronic alcohol use. This condition can lead to irreversible damage if not treated promptly with thiamine replacement. Acute alcohol intoxication, option B, can cause confusion and ataxia but does not typically cause the neurological findings like nystagmus and ophthalmoplegia. Stroke, option C, can cause confusion and ataxia but would typically present with focal neurological deficits and would not cause ophthalmoplegia. Alzheimer's disease, option D, usually presents with progressive memory loss and cognitive decline but does not cause the acute presentation seen here. Question 30. A 45-year-old woman presents with a 3-week history of right upper quadrant pain, jaundice, and dark urine. She has a history of obesity and type 2 diabetes. Laboratory studies reveal elevated liver enzymes, bilirubin, and alkaline phosphatase. What is the most likely diagnosis? A. Acute viral hepatitis. B. Cholecystitis. C. Gallstones with cold lithiases. D. Hepatocellular carcinoma. Answer: C. Gallstones with cold lithiases. Explanation: this patient with right upper quadrant pain, jaundice, dark urine, and elevated liver enzymes, bilirubin, and alkaline phosphatase is most likely suffering from cholelithiasis, which occurs when gallstones obstruct the common bile duct. This condition can cause both hepatocellular and cholestatic liver enzyme elevation. Cholecystitis, option B, typically presents with right upper pain and fever but is less likely to cause jaundice and elevated alkaline phosphatase. Acute viral hepatitis, option A, would present with elevated AST/ALT but is less likely to cause obstructive jaundice. Hepatocellular carcinoma, option D, can cause jaundice but usually presents with more nonspecific symptoms and a history of liver disease.